I'm a Home Start volunteer. Of course I care about supporting local families. I'm a Home Start volunteer. Of course I've had free training to do my role. I'm a Home Start volunteer. Of course I have fun while I'm helping others. I'm a Home Start volunteer. Of course we welcome new people.
If you want to be a Home Start volunteer like Becky, visit the links below. Home Start, giving extra support to local families near you.
Do you hear
I'm a
that?
Home Start volunteer.
Do you hear that? Want to be a Home Start volunteer? Is it for you to go online or you go to the center? You apply and do the course or do the training. So it's one of the volunteer. I just linked to my link so you can hear one of them, their voice.
Of course I care about supporting local families. I'm a Home Start volunteer. Of course I've had free training to do.
And this is nobody but your lady, Victoria Family Life. Thank you. Keep on watching or listening to another professionals.
Do my role. I'm a Home Start volunteer. Of course I have fun while I'm helping others. I'm a Home Start volunteer. Of course we welcome new people.
If you want to be a Home Start volunteer like Becky, visit the links below.
Yeah, that's
Home Start, giving extra support to local families near you.
so guys, you can go online. You can go online and apply. Or you walk into the centers. The one that close to you, near you. You can go there. Sorry for a short break. I can bring for you Autism. Sorry for that short move. Okay, bring for you Autism.
Yes. All along the spectrum. So, but we never really heard it referred to as spectrum until the last few years. What does that mean?
There's a lot of confusion about these terms and what they mean. When we discuss autism spectrum disorder, essentially it means the same thing as autism. Everything is all under one umbrella. So in previous iterations of our diagnostic and statistical manual, we had 4 different conditions that were separated out. As of 2013, all of those categories have been collapsed underneath of the autism spectrum umbrella. And that's just a recognition that there are all different versions of autism, ranging from individuals that are nonverbal and who communicate and interact very minimally to people that are actually very bright and gifted in some cases, but still have difficulty in social arenas.
What is Asperger's syndrome?
So Hans Asperger was an Austrian pediatrician, actually, who did a case series on several boys that he felt had unusual but common to each other characteristics. So Asperger syndrome refers to individuals that are on the spectrum, but very high functioning in terms of their IQ and their verbal skills. So often they can talk a lot about things of interest, but that social connection piece is still missing. In addition to that, they have difficulties in this behavioral aspect of autism, which would be like the obsessive interest or the overfocus on things, the rigidity to the point that it causes problems for them in daily life.
So Asperger's syndrome is just a stop on the spectrum.
Exactly.
Is this truly more common than it used to be, or are we just hearing more about it? It's just more often diagnosed?
I think that it's, we're hearing more about it now, and it's more often diagnosed. So both of those things. But in terms of the actual numbers of people with autism, we don't think that that has changed a whole lot over the years. And there's lots of studies that have supported that. The differences, though, are in medical providers recognizing what is autism, so that full range or spectrum that we talked about. We used to think that people that were on the higher end of that spectrum didn't have autism. And so there was a whole group of people that weren't considered autistic because they were getting along okay, or they were having some difficulties, but they still had good intellectual ability, and so they weren't identified.
Sure, they're quirky.
Right.
Or they're just standoffish, or they're, geniuses, whatever.
Right.
It's interesting to me that that is part of the spectrum.
Mm-hmm. It can be if it causes impairment. So that's a really important point, because being quirky is a lovely part of the human condition that we don't want to pathologize. But if the quirkiness arises to a level that it's causing problems for the person in their everyday life, and they're not able to do things as they need to on a daily basis, like function in school or function on the job, then that's where we start to get concerned that this might have crossed the line from quirkiness into something that's actually a disorder.
What I think is interesting is if you have this whole great big spectrum from high functioning to very low functioning, how in the world do you diagnose it then?
This is, it's not an easy task. When children come to us and they have pretty obvious symptoms, often we can diagnose autism even in the first year of life, but definitely in years 2 to 3. But when individuals have good intellectual ability, good verbal skills, then it can be much harder to tease this out. And that's when we're not able to identify sometimes the full picture until a little bit later in childhood.
And what are those symptoms that are most common?
So the symptoms of autism, again, really vary based on the particular version of autism that we're looking at. But in general, the difficulties that they have are common across all of those individuals. And some of the more common ones are difficulty with nonverbal aspects of communication, so difficulty with eye contact, lack of facial expression, sort of a flat expression, lack of reaction to things going on around them. Often these individuals don't understand personal boundaries, so they'll get, too close to people and not realizing that they're violating personal space. They have difficulties in conversation, sort of that back and forth volley of, you say something and then the other person says something, kind of that exchange is hard. And often they don't seek out social interaction as often. So they're perfectly happy in many cases to just kind of experience things on their own and not to share things that they're excited about or interested in with other people around them.
Can you move along the spectrum? This is the part that I'm most curious about, because just in the last 25 years, looking at it as a spectrum, I think parents, when their child is diagnosed, they just think, okay, my child has autism, is on the spectrum, but how can we help them be more high functioning as they grow up? Because you're going to grow up and you have to have a life.
Right. So that's the whole point and the whole reason that it's important to get identified as early as possible and to get intensive treatment and therapies as early as possible. There's actually a growing body of research that is suggesting to us that there's a small minority of children who are diagnosed very early on with autism that actually improve so much that the autism isn't detectable later on when we take another look.
Wow,
and
is that encouraging?
It is. It's very encouraging. And it's not that those kids don't have any issues. Often they have residual anxiety, or they have attention problems, or maybe some mild language issues, but they no longer meet full criteria for autism. So that's sort of the best case scenario. That's not how it goes for most kids and families, but our treatments are better than they've ever been before. And if we can get kids identified early, we have the best opportunity to help them get the level of intense services that are needed to move them into the range that they will have more success in daily life.
What's the earliest you've ever diagnosed a child with autism? And are they usually referred to you, and it's because the pediatrician sees them and suspects, or the family physician suspects they might be autistic?
They come to us for both of those reasons, but I have to say that when we are able to diagnose children very early, under the age of 2, it's usually because parents are astute and they know that something is different about this child, the connection is different. The child maybe doesn't interact with them in the same way or smile at them in the same way. Eye contact can be amiss. And so usually when we're able to identify children very early, it's because parents have spoken up to their pediatrician or other provider and said, hey, I'm concerned. And then that provider listens and sends them on for further evaluation.
Is it true that autism spectrum disorder affects 1 in 59 children?
It's true.
That common.
Mm-hmm.
But you think it's always been that common, we just didn't identify it.
That's
Didn't
what the research
recognize
is
it.
showing us. Mm-hmm.
Speaking of research, what is it that causes autism?
That's the $1 million question.
Because we want to know why. I mean, whenever we talk about autism, I just think about the parents that every day want to know why and then how to go forward. So let's talk why.
Yeah, that why is important. It's really important for some families, less so for others. But what we know about the cause of autism is that there is definitely something genetic. And if we look at the chromosomes of these individuals, about 15 to 20% of them have some kind of abnormality in their chromosomes that predisposes them to have autism. But we also know that that genetic difference is not enough, in most cases, to turn that gene on, that there's something else environmental that's happening with these children that is allowing that gene then to be expressed. And the environmental causes, we're still trying to figure out what all of those are, but the ones that have been most substantiated are things that happen very early in development. So parents, both moms and dads who are older at the time of conception is a contributing factor. Any difficulties during pregnancy, like an illness that mom might have for a longer period of time, not just like a cold, but something that lingers and hangs on a bit longer than that. Also, any problems during delivery, where the child doesn't get oxygen for longer periods of time, and children who are born preterm, very preterm, usually 24, 25 weeks, somewhere around in there, and also kids that are born little, so low birth weight babies.
How about any relationship to the age of the parents
Yes.
at the time of conception?
Yeah, so we used to think that it was just older moms who were contributing a risk factor then for children to develop autism, but now we know from the research that it's both older moms and dads have a higher risk of having a child with autism.
And boys are 4 times as common as girls.
Yes.
How do you explain that?
We don't know the answer to that question yet. I mean, in general, boys have more genetic and medical issues than girls. So girls have more of a protective factor with having 2X chromosomes, but we don't fully understand it. There's some mice model research that's suggesting that things can go awry more easily in male brains in terms of imitation and social skills. And so we think that when a problem happens during pregnancy or something is amiss, that affects boys differently than it affects girls.
Fascinating.
Any evidence that there is a relationship between vaccinations and autism?
No, there's not a relationship between those two things, but unfortunately, many parents still believe that. And I can understand why. There was some initial erroneous and unethical research that was published, and when you're a parent and you're looking for an answer, sometimes these things seem like they make a lot of sense. So a lot of people have looked to this and wondered about their own children if that was the cause.
But wasn't that research retracted
It
later
was.
on?
Yes.
Yes.
And that individual lost his license to practice medicine and has since not been able to practice anymore. So there are lots of issues with that particular paper, but unfortunately it's still out there. And so people ask questions about this all the time. Many times when I have this conversation with parents, I am not able to change anybody's mind, and that's not what I'm trying to do, but just trying to present the research and then directing them to do their own reading if they would like. But there have been hundreds of follow-up studies to that initial study that showed that there might be a relationship between vaccines and autism, and they have not shown that there's any link.
Our guest, an expert on autism spectrum disorder, Mayo Clinic psychologist, neuropsychologist, Dr. Andrea Huebner. Time for a short break. When we come back, we'll talk a little bit more about diagnostic criteria and the importance of starting treatment early. Neuropsychologist, Dr. Andrea Huebner.
Because you're a brain doc, I just have to ask a brain-related question here. Because you're talking about brain development, and we know that that continues on into their 20s. Do people with autism, do children become young adults with autism, do their brains develop the same way that other 20-year-old brains, teenage brains develop, or do they develop differently?
It's both, actually. I mean, if we look at the brains of very young children with autism, in many cases there are no differences between kids with autism and kids who don't have autism. Really, the differences are in the functioning of that brain, so things that are happening at a level that we can't see with our standard tools. So if we would put two individuals in fMRI scanners where we're asking them to do a task and we're looking at the brain at work, we would probably see differences between people with autism and people without. But just in terms of a static picture, there's not a lot of difference in some cases. In some cases there are. But in terms of the brain development across the lifespan, if they started out having a brain that worked differently, then that usually continues throughout development. If they started out with a pretty typical brain, then that's kind of what we tend to see too as they mature. But it's really the way that the brain is working rather than what the brain looks like as a whole.
How do you help patients and their families, their parents, move forward with life when you have diagnosed them on the spectrum?
You know, this is a process. It's not something that we accomplish at any particular visit. It's through developing a relationship with the child and with the family. And what we like to do is to really guide the family through this journey, this path that they're on. There are high moments when kids are successful and they meet goals and they're doing well, and then there are harder moments too, just like when you're parenting any child. So I try to meet the parent where they are, wherever they are on that path, and just provide support and guidance at that time. Another thing that I think is really important is that as medical professionals, we're taught to define problems and to collect information to support diagnoses. But there are so many positive things about kids with autism, just like kids who have any other condition, that I really try personally to focus on more of those. It's not helpful to parents to focus on all the limitations, but part of what we do with our testing and diagnosis is to find those strengths, and parents can tell us about those strengths, and then we use them to build skills so that the child can be as successful as possible.
What are the most effective treatment regimens in your experience?
So the most well-researched treatment for autism is something called applied behavior analysis, or ABA therapy. For most children that are diagnosed with autism, I would say under 5 or 6 years old, this is the treatment of choice. It's a very intensive treatment, so often this involves 25 to 40 or so hours of therapy per week. The therapy is individualized to the child, so assessments are done to determine how the child is performing in communication and social skills, for example. And then typically they work one-on-one with a behavior specialist to try to improve skills one little piece at a time. And this is done by shaping behavior through reinforcement for the most part. So
applied behavioral analysis.
Applied behavior analysis, yes.
One last question about, we mentioned the fact that this could potentially be genetic. Should kids who have been diagnosed with autism have genetic testing?
We do recommend that children who are diagnosed with autism receive genetic testing. That's the recommendation through the American Academy of Neurology, and we follow that here. This is often helpful for parents who do want to know the why, because, as I mentioned, about 15 to 20% of the time we can find the why in that testing, but more often than not we can't. It's a process that's helpful for some. When there is some kind of abnormality or difference identified, though, it can be really helpful for us as medical providers to know how to help that child, because often there are medical associations with a particular abnormality. And so we might want to do different surveillance screens or follow-up things that we wouldn't do in a typical child, or if we didn't know that the child had that underlying difference.
Can you grow out of autism? Is that a possibility that a patient can have?
So,
or should we even look at it that way?
I'm sure there are people that would say we shouldn't look at it that way, that autism is just another difference in humans. However, autism also in many cases comes along with some struggles and some difficulties. So I think it makes sense to try to help the child develop strengths in that area so that they can have an easier time and kind of get along easier in daily life. In terms of growing out of autism, the whole goal of early intervention is to help the child develop the skills that they don't have naturally, to develop better communication and social skills. Will they develop to the point that they won't have any difficulties in those areas and they'll look typical? Probably not. But if we can get them to a higher level of functioning, that's the whole idea.
Are there any alternative therapies that you have found effective? And I'm thinking of vitamins, supplements, diets, special diets, any of those?
Parents are often interested in trying these things because they want to do whatever they can to help. For children who have GI disturbances like constipation and diarrhea, those things are much more common in children with autism than in kids who don't have autism. Or if they have celiac disease, definitely, then something like a casein-free, gluten-free diet would be recommended and can be helpful for those kinds of children. But for children that don't have that kind of disturbance, there's no evidence to suggest that something like that or any other special diet is helpful. Vitamins are helpful to the extent that they are for any child, but not necessarily specific to autism. There's also some troublesome treatments, alternative treatments that are targeted for individuals with autism, such as hyperbaric oxygen, and chelation therapy. And these are actually not advised because they can be very dangerous for kids. And there are also cases, more than one case of children dying by when they go through these procedures.
None as good as applied behavioral analysis.
None is good.
All right, autism affects 1 in 59 children in the United States. We don't know what causes it. We don't know how to cure it, but we do know that the earlier therapy is started, the better the outcome. Our thanks to Mayo Clinic psychologist, Dr. Andrea Huebner. Thanks so much for being with us.
Thank you.
Okay, so thank you very much for coming today. And welcome to the introductory lecture on autism. In this lecture, we'll focus particularly on how autism expresses itself in the first 3 years of life. We're going to talk about core features, comorbid characteristics. We'll talk a little bit about broader autism phenotype and spend some time trying to understand what might be the earliest signs of autism that are present in babies way before behavioral symptoms of autism come online. Autism is a complex neurodevelopmental disorder. It affects in a profound way how children interact with other people. Also produces a series of very unusual behaviors having to do with rigidities, repetitive motion, and stereotype interests. It's one of the most prevalent neurodevelopmental disorders, affecting 1 in 68 children in general population. Thus far, we really don't have biological markers or medical tests that can be performed to determine whether the child does or doesn't have autism. For that reason, in order to diagnose the child, we have to perform a close analysis of the child's symptoms and behaviors. It's a very complex task, particularly in young children, because the expression of autism is tremendously heterogeneous. Some children with autism have tremendous sensitivity around other people, and they are perturbed, sometimes even by proximity of others. Other children are actually very interested in interacting with other kids, but they lack basic knowledge of how to carry these kind of interactions in a successful manner. Some children with autism will never develop speech. Others are very talkative or verbose. Some children have tremendous learning difficulties. whereas others are very bright and talented in many different ways. So the expression of autism sort of varies along a number of dimensions, and we are still probably to identify other dimensions along which our children differ. What also complicates diagnostic differentiations early on is that it's a developmental disorder. What it means that the symptoms of autism are expressing differently depending on the child's age and cognitive level. So we can expect quite different set of symptoms in an 18-monther than in a 5-year-old, than in a 16-year-old, and in someone who's 25. So anytime we see a child for a differential diagnosis early on, we need to be very mindful. What can we expect from the child from the developmental standpoint? Of what kind of symptoms would be most diagnostic at a given age? What's important for our discussion today is that autism starts before the age of 3. And this is the developmental period where we'll be focusing on during this talk. So what are the core characteristics of autism in a young baby or in a toddler? Where I think the first thing that we all notice when we walk into the room and the child may have autism is that they are not really paying attention to things that otherwise are tremendously important to children without social disability. And these two things are faces and voices. And actually limited attention to faces and limited orienting to voice or one's name is sort of one of the first things that parents begin to notice when they begin to worry about autism. Another thing that's quite diagnostic and specific to autism is a limited drive to share experiences with others. If you ever interacted with a 12-monther or 14-monther, you know they cannot do a lot, but what can do is to pull you into their world of experiences by giving you something, pointing something, showing you something, for no other reasons, just for sheer pleasure of joining in the same kind of experience. This kind of set of behaviors is profoundly lacking in children with autism. Most or all our children, when we see them for differential diagnosis, have delays in language, and this is not specific to autism. A lot of children have delays in language, and they are sometimes consequential, sometimes not. What's very specific to autism is that our kids have major difficulties in communicating with other children non-verbally. They are not using their eyes, they are not using their facial expression and gestures to convey meaning to other people in the absence of speech. And that affects how they interact with the world, and in fact affects quite profoundly what they learn from the world as well. At this age, we are beginning to see emergence of speech, but speech, when it comes online, it's often stereotyped and not always fully functional. So children not always use the words they have to communicate in an adaptive way. The speech is often repetitive, involves naming, repetitive naming of objects around, or repeating verbatim question or phrases by other people. Already in the second year of life, we are beginning to see emergence of repetitive behaviors, restrictive behaviors, and unusual movements. They're not horribly necessarily pronounced, and sometimes it's difficult for someone who's not well trained in this population to detect them, but we're beginning to see seeking or avoiding of certain sensory stimuli, not protecting ears from the sounds, or seeking spinning objects. Instead of playing with toys with a track, the child may turn it around and start flipping the wheels, or begin to show some unusual movement. It could be just subtle finger movements or toe walking. Again, not very pronounced, but present. So when does autism really emerge? When do we begin to see behavioral symptoms of autism that we can actually diagnose? This question has been on our minds for decades. And when I say our minds, I mean researchers in the field of autism. And we asked this question in multiple ways, using a retrospective parental report, and more recently by following up babies who are at risk for developing autism. And it turns out that in the first year of life, it's really hard to see the kinds of symptoms that we would expect in a toddler. So we cannot sit with the baby, play with the baby, and see, for instance, poor eye contact or some gaze aversion, or these behaviors are really not coming online that early. By about 12 months, we are beginning to see delays in social communication, in use of gestures to communicate. There might be some withdrawal from enjoyment of social interactions. And parents see it and clinicians see it, so these behaviors are noticeable. The only thing is that they are not horribly diagnostic. The reason is that some children who have these difficulties at 12 months actually grow out of them. And some children who have autism are actually still okay around 12 months of age. So we are beginning to see emergence of the symptoms, but they are not yet diagnostic the way we define the symptoms or the things we are looking at. By 18 months, however, it's only 6 months later, we can reliably diagnose about 40 to 50% of children with autism. And that proportion increases dramatically afterwards. So what does autism might look like at 18 months? This is a time when we say, well, if the child seems to have symptoms, the child probably has autism. So in order to answer this question, we did something very interesting. We pulled data from across several sites in the US and in Canada, and we recruited infant siblings of children with autism. As you might have heard, due to genetic liability, these siblings are at enhanced risk of developing autism themselves. So with 700 children, we had a lot of power to actually ask a question: what are the unique combination of features that are predictive of later diagnosis of autism amongst younger siblings of children with autism? And we use a machine learning algorithm, something that we call, it's called classification and regression tree approach, in which we outputted ratings of the child's social and communicative behaviors, repetitive interests on 30 different items. We allowed for all possible combination of these features to be entered into the model, and then we asked the algorithm to select those features that are most predictive of later outcome. And we found something really interesting. If you look at this little tree, this is the little tree, it tells us which symptoms predict autism. And what we found is that there's a couple of groups here on your right, which are were put into this category because they have unusual eye contact, they don't share or engage others in their world or activities, and they also have very poor communicative gestures. And so there was a group of children with autism, and these are the prototypical symptoms that we will be looking for at 18 months in if we were to look for autism: lack of eye contact, no sharing, and poor communicative gestures. So that was great. On the other side, however, we also have some kids with autism, but they were identified by a combination of different features. These kids had actually pretty good eye contact, and they were not that bad in a face-to-face interaction. What they were lacking, however, is this sort of behaviors that aim to engage other people in their activities, and they were showing some emergent repetitive behaviors. So why different features predict different subgroups of kids with autism? Well, when we looked actually at their verbal and nonverbal skills, here on the bottom, we found that the children who were showing this atypical combination of features were actually much higher functioning than those that were showing a very prototypical symptoms. What does it mean? This means that our current diagnostic criteria may be calibrated toward children with greater cognitive and language delays, and might be missing children who are higher functioning, especially at this very, very young age. Something to keep in mind as clinicians as we are interacting with children in diagnostic context. The implication of the study is that right now diagnostic tools and screening tools work on the assumption that one size fits all. What we are saying is that we might need to begin to calibrate to increase the precision of a diagnostic evaluation. We might need to calibrate the screening and diagnostic procedures to specific subphenotypes within the spectrum. One of the most important things that we were concerned when we started diagnosing children at such early ages is what is the stability of the diagnosis at this age. And what we found, and this is research here at Yale, in England, other colleagues in the US that follow children for 1 year, 2 years, 5 years, 15 years, is that the stability of early diagnosis is quite high. 80 to 90% of children retain the diagnosis, and those who don't often have some residual difficulties or some other related problems. Predictors of later outcome when we see babies very early on are pretty straightforward. Less severe autism symptoms, higher cognitive skills which enable children to learn faster, and greater rate of progress over time. What also helps children in terms of overall outcome is not to have comorbid disorders, and I'm going to talk about this in 1 second. So I mentioned at some point a moment ago, I mentioned the special population of children within general population, which are younger siblings of children with autism. Prevalence of autism is about 1 in 68 children in general population. There are certain subgroups of our population where the prevalence of autism is much higher. And it's very important that as clinicians we are aware of that, because that might sort of put a radar on anytime we see a child with a specific syndrome or risk factors that they might be, that we need to monitor these children also for autism. So one of the groups that's at the greatest risk for developing autism are younger siblings of kids with autism. The reason is genetics. And as you might be aware, genetic factors are extremely powerful as etiologic factors in autism, with concordance rates for identical twins being around 80% or so. So for siblings who are not identical genetically, the concordance rates are somewhat lower. And depending on the estimates, they differ between 1 in 10 or 1 in 5. So 1 in 10 or 1 in 5 of younger siblings of children with autism are likely to develop the disorder themselves. Now, this number is moderated by several other factors. One of the factors is how many children with autism there are already in the family. If there are 2 children with autism already in the family, the risk doubles. The risk for a younger child to develop autism goes up to 30-40%. Another very important factor is the sex or gender of the younger sibling. And you can actually see it here in this graph, where we have a comparison of recurrence rates amongst boys and girls as younger sibs. And you can see the boys are much more likely to develop autism than girls. And the risk factor goes up about twice. It's twice as high in boys than it is in girls. There's one more factor that's really fascinating, and there's a lot of work going on right now trying to explain this, is this gender or sex of the older sibling. All right? So if the older sibling, and these are the bars right here, if the older sibling is a girl versus a boy, then the likelihood of the next child having autism is much higher. And it has to do with, we think it has to do with the genetic load that girls need to carry in order to reach affectation status in autism. So this is all new emerging science, and you probably will be hearing more about that. Important to think about it when speaking with the parents. Now, the siblings, as you often hear, we are dealing with a spectrum, right? Autism spectrum, which means at one end of the spectrum we have autism, and the other end of the spectrum we have no autism, so to speak, but there's everything in between. So when you look at this figure here on the right, you can see that sort of metaphorically that if we think that there are children here who have autism, younger siblings who have autism, and then children who are developing typically, there is a group in the middle. And this is the group we call broader autism phenotype. These are the children who are at risk for developing some social difficulties, not necessarily meeting criteria for autism. And they are also at risk for developing other difficulties. Already when they are as young as 18 months or 24 months, we see that there's a significant proportion of younger siblings of children with autism who have language delays, social difficulties, emotional regulation difficulties, motor difficulties. And what's very important to keep in mind that when these children grow older, during school age and adolescence, these children are twice as likely to develop affective disorders, anxiety, ADHD, and a host of other difficulties. So again, the reason why I'm bringing it up is that we need to be very sensitive to clinical needs of younger siblings of children with autism who do not develop autism themselves. And if there are symptoms present, we should be actually acting on them, not worrying, is it autism, is not autism? It's irrelevant. If the child is facing difficulties because of their vulnerabilities, we need to intervene. It might, in fact, prevent some of the later mental health disorders that we see quite so frequently in this population. There are other groups that are also at increased risk for autism, and one of them are preemies. And as you can see here on the top, the risk for autism increases as the gestational age decreases, which is very high risk for autism in babies who are born with gestational age of 23 or 24 weeks. It's about 15% or so, whereas the average for the entire preemie group is 7% or so. There's a number of genetic syndromes where we see higher incidence of autism, including Angelman syndrome, Phelan-McDermid syndrome, and more recently, congenital heart disease. That group is still under investigation. We don't have a lot of really good studies evaluating prevalence of autism in this group, but current estimates sort of vary between maybe 3, maybe 5% or so. I'm sure we'll hear more about it in the near future. Sex differences in autism, right? Like many other neurodevelopmental disorders, boys are more likely to develop autism, right? If you read DSM-5, the ratio quoted there is 4:1, 4 boys, 1 girl. If you look at more recent studies that actually are based on populations that are not as, there may be less bias or more inclusive, the ratio actually goes a little higher, goes down, and the recent estimates suggest 3:1. It's a very interesting question. Why, right? Why more boys? Why fewer girls? When we look at the severity of autism symptoms between boys and girls in terms of social difficulties, the severity is quite comparable between the groups. The girls, however, present themselves somewhat differently because they have typically fewer or not as intense repetitive behaviors, and also they tend to be more introverted, have more anxiety, have more depression, so they tend to be a little bit quieter. Boys, on the other hand, are very visible, a lot of stereotypies, and they're also very rambunctious, very active, and prone to externalizing disorders, including behavioral problems. So they are very, very, very visible. So in our field, again, this is one of these areas to watch in the coming years. So we've been asking the question, what produces this disparity between males and females? One set of answers have to do with how we diagnose the kids. Is the current diagnosis sort of a social construction, or is the disparity due to biological factors? These two hypotheses, or these two groups of hypotheses, are not mutually exclusive. They are probably both, most certainly both at play. So let me tell you about the first one. So why do we have fewer girls than boys? Very interesting. Several studies evaluated severity of autism symptoms in large population of children in England, in the States, and they found that boys and girls may have the same severity of autism symptoms, but boys are more likely to receive a diagnosis of autism in their community. Right? So there's some kind of a diagnostic bias that sort of prevents girls who are clearly socially vulnerable from receiving the diagnosis and being treated appropriately. And the idea is that perhaps the diagnostic criteria that we are operating within have been created based on how autism expresses in boys, not how it expresses in girls. So for that reason, it might just select those who fit that description, sort of it's a low circular sort of way of designing diagnostic criteria and using them. And this area, again, is under investigation. We'll hear more about it in the very near future. Another, the biological factors that have been sort of proposed to account for this disparity are heterogeneity, for instance, in terms of etiology, that there might be different factors, both genetic and environmental, that give rise to autism in males and females. The hypothesis that has been more strongly supported recently is a hypothesis which suggests that the ratio is due to the fact that the girls may have some kind of protective factors which are preventing them from expressing symptoms of autism unless they receive a major genetic hit. So in other words, they need to have more atypicalities in terms of genetics, genetic or epigenetic factors in order to reach affectation status. We don't know exactly what these protective factors might be. There are several hypotheses, one suggesting that there might be some genetic X-linked factors that are protecting the girls, or there might be some hormonal factors that also are sort of lessening some of the edges or around the social difficulties. Speaking of protective factors, we did a study not long ago where actually we described probably one of the first, or if not the first, sort of evidence for potential protective factor already in young babies. This is a study in which we use eye tracking technology to evaluate how babies allocate attention in response to a person who is sort of interacting with them, speaking to them, making eye contact. There's some toys. You can see the example of a screenshot from that video. So then at a given point, the child needs to make a decision where to move their eyes. And we conducted a study in 6, 9, and 12-month-old younger siblings of children with autism. And then we compare how high risk and low risk, these are the children without an older sibling with autism, perform on this task. In the red, you see girls, solid line, girls who are at high risk for autism. In black, you see boys, solid line, boys who are at risk for autism. And as you can see, something is really interesting. This red line is really, really high, both in terms of overall attention to the task or to the social scene, and also in terms of attention to the face of the speaker. It's a very interesting, intriguing, and puzzling finding. It might suggest that younger sister of children with autism very early on are employing perhaps compensatory strategies to try to get some more out of social interactions, try to maybe remedy some of the vulnerabilities they have. And we are following up these studies, and we might have an answer what it actually is and what it does. But this is a first illustration of a potential protective factor already in infancy. So just to sum up our clinical implications of the discussions we just had, early diagnosis is stable. We have tools to diagnose children in a reliable way. We need to be very careful how we do it, because we need to consider multiple factors, not just symptoms of autism, but also the child's language, cognition, family factors, medical factors. But when we take it under consideration and the child's presentation is consistent with autism, that diagnosis is relatively stable. There's no reason to wait for anything. There's a reason to act and help families move toward toward implementing intervention services. Important to keep in mind that not all toddlers are going to be very prototypical. Right? The girls might look a little different. They might look better. They might be camouflaging some of their difficulties. Also, kids who are higher functioning might be not quite showing the prototypical symptoms that we expect at this age. Given the high risk that we know that number of populations or subgroups within our population has enhanced risk for autism, we have a mandate to actually monitor these children and screen them to make sure that we detect social difficulties as soon as possible. And in terms of predictors of outcome, we don't have tremendously specific measures, but just on a very general level, having better cognitive skills, verbal skills, and lesser severity, better progress or response to treatment within the first month typically bode well with later outcomes. All right, so we covered core symptoms of autism, and I wish this is where we could end. I wish this was all the problems children with autism and their families had. It's not true, unfortunately. The problem is that 70% of children with autism has at least one comorbid condition. And when I say comorbid condition, I mean a diagnosis of ADHD, affective disorder, anxiety, schizophrenia, many other disorders. Their prevalence is higher than in general population. So, and some children, or a lot of children, actually have more than one comorbid disorder occurring. What it tells us is that the factors that are driving psychopathology are overlapping to a large extent. But what happens is that when a child with autism has a comorbid disorder on top of it, it never bodes well for the long-term outcomes. These children struggle more. They have more difficulties in adaptation, social functioning, and they are less likely to get more, they may have trouble getting an educational placement that's better matched with their overall skills. There's a high risk of hospitalization, suicidality, and many other problems. For many years, these kind of problems were overshadowed by autism, and we typically did not diagnose comorbid disorders in children with autism. It was like, oh, he has autism, so he's active. Oh, he's moody because he has autism. DSM-5 changed that, and right now a child with autism can carry co-occurring conditions as well. What's important is that for us as a clinician to also keep in mind that we are not horribly well equipped to differentiate or diagnose these disorders in kids with autism, because there's so much mushing around of various symptoms and their manifestations. There's a lot of really good work happening right now in our field to create better screening instruments for anxiety, for instance, or ADHD for children with autism, and also to create treatments that would be effective in children with autism as much as they are effective in general population. So again, something to think about, look for, and more information is coming. Why is it important when we talk about toddlers, right? Because we're focusing on kids under 3. We typically don't diagnose anxiety, ADHD, affective disorders in kids under 3. So why am I talking about it? Well, I am talking about it because we know from extensive research in general population that there are certain precursors or signs of upcoming difficulties, internalizing, externalizing problems already in infancy. And they are conceptualized under the umbrella of temperament, which is sort of a biological tendency to respond in certain ways with regard to positive affectivity, joy, or negative affectivity, such as fear and anger, and also ability to regulate emotions that arise in response to internal or external challenges. What's interesting that these patterns can be detected as early as 6 months, and they are relatively stable over time. And they might be sort of shaped a little bit by experience, but they're relatively stable over time. Extensive research in general population suggests that a typical positive and negative affectivity are related to later internalizing and externalizing problems. So for us, paying attention to how our toddlers are doing in terms of their regulation and emotional expressions in response to real world challenges it makes a lot of sense. And I'll tell you why right now. So we evaluated temperamental characteristics of toddlers with autism. This was probably one of the largest studies of temperament in young children with autism. The strength of the study was not only its size, but we also compared children with autism with children with other developmental delays. I mean, it's not a big art to compare autism with typical kids. What we want to see how children with autism differ from children with developmental delays. And what we found was that children with autism seem to display less intensely positive emotion. They seem to experience less positive emotion in response to normative real-world environment. They also seem to be more negatively biased early on, and they have difficulties regulating emotions that arise when they're challenged by new things or things they don't necessarily like. What was very, very interesting is that at this age, severity of these emotional difficulties was not really associated with severity of autism, which suggests that there might be totally different domains of functioning that might arise maybe from different sources and then interact to produce complex phenotypes later on. We followed this group of children when they were 4, and there was very high stability. You can see these correlations here in the 50s and 60s. Very high stability within our group in terms of how, what were the temperamental vulnerabilities early on. What was also very important is that these early emotional vulnerabilities contributed later to a severity of autism symptoms as measured 1 or 2 years later. So it's an interesting example how 2 different domains might interact and produce complex, reinforce each other and sort of produce complex phenotypes in the autism group. So just to sum up, we have, there are very good reasons why we should be monitoring emotional development and emotional regulation in children with autism. It's not everything that you see is part of autism. It might be part of a different set of risk factors that are likely to produce symptoms later on that will make the lives of kids with autism less adaptive and lives of their families a little bit more complicated. Because of the fact that the various comorbidities come online at different ages, right? We might start with some shyness early on, ADHD, anxiety, then we get into affective disorders and so forth and so forth. There's a need of monitoring kids with autism continuously for these problems. It's not screening them at 18 months and saying, it's fine. No, because there are problems that will arise over time. So screening kids for these emotional difficulties throughout their early childhood and early school age is clinically indicated. And we hope that adequate or precise detection of these problems and intervention will help improve long-term outcomes in kids with autism. All right, we're going to switch gears now. I'm taking off my clinician hat and I'm putting on my researcher hat. Because we're going to talk about the developmental period that sort of spans between birth and about 12 months or so. And there are very few symptoms that we can call symptoms of autism during this time. So we are studying this time in development because we want to understand what's really happening. So is it true that autism really doesn't start until the second year of life? Or is it true that there are pathogenic factors which are already unfolding but they are unfolding on a level that it's more difficult to capture with the naked eye. One of a line of research in my lab is focused on trying to understand why toddlers with autism have such limited attention, ability to select for processing people's faces, especially when the people are speaking. It's a very important, it's a core symptom of autism. It's very important because we learn by directing our attention toward important sources of information. In other words, attention gates learning. If we are not paying attention to people and their faces, we not try to decode what they speak while attending to their facial features, we are missing a tremendous amount of information, which is going to affect not only how they develop language, but also how they develop social expertise. And Leo Kanner, this gentleman here, in 1943, he already noted that this kind of limited attention to people's faces and voices is present in autism very, very early on. And so what we did is we created an experimental paradigm which allowed us to replicate what we see in real world in the lab. And that replication is important because then we can take it apart. We can manipulate experimentally what children see, what do they hear, and try to understand what's generating this profound impairment in selective attention to social targets. The study involved a video. I mentioned it before, but now I actually will give you some more details. In this video, this very wonderful young woman is speaking to the camera, trying to engage the viewer using eye contact, speech. Occasionally, she turns toward materials on the table, makes a sandwich. Occasionally, the toys start moving. So the child has to decide millisecond by millisecond where to direct their precious attentional resources and where the information is, what they're going to learn from this scene. When we take a group of typically developing children and show them this video, you can see that they're behaving in a very orchestrated way.
Hi again, sweetie. How are you doing? Are you having fun? You look so cute today.
So as you can see, all children kind of converge. When she's making a sandwich, they observe goal-oriented action. When she speaks, they monitor her face. When something happens perceptually salient, they look at her face. When we repeated the study with children who have autism, and you can see the graphs down in red, this is a group of children with autism, gray, developmental delay, and blue, these are typically developing children. You can see that children with autism are not completely lost. They're behaving quite well in many respects. However, there's one situation in which their behavior diverges from the other groups. This is the situation when she looks at the camera and speaks, trying to engage the viewer in a sort of using prototypical dyadic bits for engagement. In this situation, they look less at faces than children with comparable cognitive skills as well as typical controls. Since then, we replicated the study, other people replicated the study. We also extended the study, trying to understand what are the factors that are separating children with autism from typically or developmentally delayed children. And we found that the factors that are particularly important are the factors that have to do with presence of speech or combined presence of speech and eye contact. What we also did is we asked a related question. We know that sensitivity to faces and speech is present already in newborns. When we show a newborn a face-like stimulus or we play human speech, they are capable of orienting preferentially toward these stimuli. It's a very elementary orienting mechanism, subcortically mediated, something that gives a newborn sort of a leg up to know where to find the most important things that are going to be very relevant to their survival. So what we did is we asked the following question. We see these deficits in response to speech and eye contact at 18 months. can we see them before behavioral symptoms come online? And we conducted a study in younger siblings of children with autism, and as we discussed, about 20% of them are likely to have autism. Another 30, 40 maybe, broader autism phenotype, and the remaining children will be developing typically. And we showed them the same kind of task as we did to children who already had autism. And as you can see, this blue bar is lower than even that of the children with broader autism phenotype, which suggests that already at 6 months, babies who are later become symptomatic of autism, they already are showing selective difficulty in attending to faces, especially faces that try to engage them in a face-to-face interaction. Since then, we replicated it with a different set of stimuli, and more recently, we actually replicated this phenomenon in the in a context of a face-to-face interaction. We took a very, very precise and very detailed measurement of the child's attention as the child was interacting with the person. And what we found was that was one condition in which children who later developed autism differed from those who didn't. And this was the condition when the person sat in front of the child and spoke. Not a condition when she sang or played peekaboo, it's only when she spoke, which was quite remarkable because it really shows the correspondence of what we see in real world and what we see in the laboratory conditions. So what we do from here, right? We are beginning to see signals as early as 6 months in babies who later develop autism. These attentional difficulties are likely to be driven by a typical development of brain networks that are involved in prioritizing stimuli for processing, selecting certain visual or auditory inputs over others. These systems develop very early. They develop even as early as during pregnancy. So what we are doing now, we are actually extending downward our studies and focus on late prenatal and early postnatal development. What I mean by that is that we are looking for the roots of social and attentional difficulties that we see at 6 months already during the last trimester of pregnancy and shortly after birth. So how do we do that? We do that by conducting brain imaging studies. And what we are using is the resting state functional connectivity approach. This is a very non-invasive, non-demanding, and safe approach to learning about brain function and brain development. What happens is that in a brain resting state, patterns arise spontaneously, so we can image a child who is asleep and still draw conclusions about how the brain is wired to process specific kinds of information. We can evaluate networks that are dedicated to processing visual or auditory information. We can evaluate how the networks that are involved in selection of stimuli for processing function very, very early on. The reason why this approach is likely to be effective, that we know that in older individuals with autism, some of the networks that I just mentioned are functioning atypically. So what do we know about current state of network development during the last trimester of pregnancy? It used to be that researchers thought that during the last 3 months of pregnancy, what we can see emerging in the developing brain are largely sensory networks. These are networks that are involved in processing visual stimuli, auditory stimuli, or, for instance, motor function. More recent studies suggest that even before the babies are born, there are certain foundations that are being laid for development of brain areas that are involved in emotion processing, in processing of speech, as well as social stimuli as faces. After the babies are born, in the neonatal brains, we are beginning to see the networks that are very important for us, such as saliency network, executive control network, or default mode networks, already form and emerge and become functional. And we also know that the properties of the networks are actually linked with later development. They are linked with language, cognition, and emotional development. So what we are targeting right now is something that may actually tell us something about the mechanisms that underlie early symptoms of autism. And we are tremendously excited about this work because this is truly a groundbreaking work, and we are sort of at the forefront of the new research we started. We already started enrolling families. We have over 20 families already following, which is fantastic. If you hear of any family interested in participating in our studies, please spread the word. Everything that we do in our work, everything that we do in our clinics, everything that we do in our labs is really designed toward one purpose. And this is sort of my favorite video. And the purpose is to make sure that every child can live up to their potential at their best and bring as much joy as we can to their lives. Whoops. So I wanted to thank people without whom none of the work I talked about would be possible here at Yale. We have a clinical team. We are running a clinic for infants and toddlers who are at risk for developmental disorders or exhibiting symptoms of developmental disorders. It's the Yale Toddler Developmental Disabilities Clinic. And we also have a research lab called Social and Affective Neuroscience of Autism Program. Our group is very interdisciplinary, brings experts in multiple areas, and these are people who are the most amazing people to work with, and I'm truly honored to be able to do that for so many years here at Yale. So big shout out to the entire team. And thanks to the families who really make everything that we do possible. And our funders, who have to be mentioned as well. They're tremendously important and influential in our lives. So thank you so much for your attention, and I'll be happy to take some questions now.
Hmm.